start our academic with the first presenter of this meet.
I invite Dr. Vinoda from SRM Medical College to take over.
SRM Medical College. Our first present from because of the structure, we are able to run successfully the chronological and all this. And recently, Dr. Ram has fellow trained in pediatric endocrinology. Okay. Got it. So to keep supporting us if any difficult cases to help you out. Thank you. With I will ask Dr. Vinoda to start the presentation.
Cases of congenital hypothyroidism. Am I audible? Let me start with my first case. This is regarding a 1-year-old male child who is a known case of congenital hypothyroidism on thyroxine supplementation started by a private practitioner referred here for first follow-up. There was a history of delay in attaining milestone. Upon evaluation, currently we did not find any symptoms suggestive of congenital hypothyroidism. Past history, this child is a known case of congenital heart disease, diagnosed since birth and started on anti-failure medication since birth, for which PA banding was done at 3 months of age. At around 8 months of age, the mother noticed the child had developmental delay, for which the child was taken to the outside hospital where thyroid evaluation was advised and thyroid screening was done where TSH were found to be 9 microinternational unit per ml. Hence, the child was started on thyroid at 4 mics per kg per day. When the child is currently not on thyroxine supplementation for the past 1 month since the parent chose to stop the treatment by themselves. The antenatal history was uneventful. This child was born at 33 weeks of gestation with a birth weight of 2.15 kg, and there was a history of NICU stay for 8 days in view of preterm care. As a part of routine screening, echo was done, which revealed a large VSD. Hence, the child was started on anti-failure medication since birth, and newborn thyroid screening was not done. There was no significant family history, and this child is second born out of non-consanguineous marriage. Development history revealed global developmental delay as the DQ is less than 50% in all domains. General examination and vitals were normal. On head-to-toe examination, the child was found to be dolichocephalic and with preauricular tag and exhibited a hypotonic posture, which is more in favor of syndromic association. And there were no other facial features suggestive of congenital hypothyroidism. The anthropometric measures revealed the child is underweight for age. Systemic examination revealed systolic murmur on auscultation, and the child exhibited hypotonic posture with the power of 3/5 and reflexes were present. Other system examination was normal. The child was evaluated at 8 months of age at outside hospital where TSH revealed to be 9.4. When the child presented to us at 1 year, when the child was presented to us at 1 year, 1 month of age, this is the first follow-up to us. The child was not on thyroxine supplementation for past 1 month. where the thyroid screening revealed normal T4 and elevated TSH level, which is more in favor of subclinical hypothyroidism. Ultrasound imaging done at 8 months of age revealed a normal thyroid gland. The child was also evaluated for syndromic association, where West revealed transcription transformation associated domain mutation, which is usually associated with facial dysmorphism and developmental delay. So let me summarize my case. This is regarding a 1-year-old male child who is second born out of non-consanguineous marriage, a known case of congenital heart disease with development delay, probable syndromic association, diagnosed to have congenital hypothyroidism on thyroxine supplementation since 8 months of age, brought here for first follow-up with a thyroid profile revealing normal free T4 and TSH more than 10 without thyroxine supplementation is highly suggestive of subclinical hypothyroidism. As the child was not under thyroxine supplementation for the past 1 month, we have taken it as an advantage and proceeded with nuclear imaging, and the parents were also willing for nuclear imaging, where the scintigraphy revealed normal uptake over the left side of lobe and the reduced uptake over the right lobe of thyroid gland, which is more in favor of hypoplastic right lobe of thyroid gland. So parents were counseled regarding the necessity of thyroxine supplementation and restarted with thyroxine supplementation at 3.5 mics per kg per day. Let me now invite Dr. Gayatri ma'am to speak a few words regarding the above mentioned case.
Thank you, Doctor. I'm Dr. Gayatri, Assistant Professor from SRM. So I would like to just add a quick addition to the cases about this child. So in this child, newborn screening was missed actually. So ideally in a preterm or SDA child, the TSH level and the T4 level after 2 to 3 weeks of the initial screen, because the TSH surge, which happens in the case of term babies, is absent in the case of preterm, where the TSH level usually plateaus up. So we may tend to miss the congenital hypothyroidism in those kids. So it is ideal to repeat it after 2 to 3 weeks of the initial screen, so that we can pick up a lot of congenital hypothyroid in those kids as well. Okay. And in this child, we found that the free T4 was not done and only TSH was done. It is ideally, as said, it is better to do a free T4 and the TSH, as most of the central hypothyroidism cases might be missed where the TSH elevation will not be there. Okay. And next is that we took this child as an advantage, as this child, the parents themselves stopped the medication for almost 1 month. Ideally, nuclear scan, the literature says that the TSH level should be at least 30 micro international unit per liter, so that it gets a good uptake on the nuclear scan. But we were in dilemma, as this child is in just 1 year and age constraint, and we wanted to start, but as the parents were also willing to go ahead with the diagnosis, what is the form. So we had a word with the nuclear medicine experts and then we proceeded. So it is but still we could get a diagnosis in this child actually. As this child had a minimal requirement, on contrary to the next case, which you will be seeing in the later half. So this child, we suspected mostly of the thyroid agenesis and the dysharmonogenesis. And last but not the least point, it is important to monitor, screen all congenital heart disease child for both cardiac and the hearing defects, as both of them are associated with around 20% incidence in congenital hypothyroidism. So that was a quick point that I wanted to highlight. So thanks to Vinoda, back to you. You can proceed with the next case.
Now I'll proceed with the second case. This is a 4-year-old child who is a known case of congenital hypothyroidism, referred here for further management. There was a history in attaining age-appropriate milestone, but the child eventually caught up with the motor milestone. History of speech delay was present. Upon evaluation, there was no other history suggestive of congenital hypothyroidism. At 1 month of age, the mother noticed that the child had refusal of feeds along with decreased activity. Hence, thyroid evaluation was done at outside hospital, which revealed a high value of 941. Hence, the child is provisionally diagnosed with congenital hypothyroidism and started on thyroxine supplementation. Regarding the dose, the documents were not available. The antenatal history was uneventful. This child is born at 37 weeks of gestation age with a birth weight of 1.9 kg, and there was a history of NICU stay for 3 days. Newborn thyroid screening was not done. No significant family history, and child is third born out of non-consanguineous marriage. Development history reveals the isolated speech delay. General examination and vitals were normal. On head-to-toe examination, except right hand polydactyly, there was no other facial feature suggestive of congenital hypothyroidism. The child anthropometric measures were normal and systemic examination was normal. When we have evaluated when they have evaluated at 1 month of age, the TSH was around 941. Upon subsequent evaluation, the child was found to have a good control. But at 2 years, 5 months of age, the T4 level was 1.02 and TSH were elevated. It indicates the parents were uncompliant with the therapy. When the child was presented to us at 4 years of age, that was the first follow-up to us. The free T4 were 0.75 and TSH was 0.35. Since the child has crossed 3 years, we want to see the etiology of the cause for congenital hypothyroidism. Hence, thyroxine supplementation was stopped for 2 weeks, and we have repeated thyroid screening after 2 weeks, which found the low free T4 with the significantly elevated TSH level, which is more in favor of thyroid agenesis. The child was ultrasound imaging done, which revealed hypoplastic thyroid gland. Hearing assessment was done in view of isolated speech delay, and it was normal. This is regarding a 4-year-old male child who is third born out of non-consanguineous marriage with isolated speech delay, diagnosed to have congenital hypothyroidism on thyroxine supplementation since 1 month of age, brought for first follow-up. Child had poor complaints with thyroxine therapy initially, which subsequently improved. As we want to determine the cause for congenital hypothyroidism, we have proceeded with nuclear imaging, where the scintigraphy revealed no uptake over the thyroid bed region and no uptake elsewhere in the head and neck region, which rules out ectopic thyroid gland. So this scintigraphy reveals more in favor of thyroid agenesis. So the parents were counseled about the necessity of thyroxine supplementation to be continued lifelong, and he was started on thyroxine supplementation at 7 mg per kg per day. So let me move on to discussion. Congenital hypothyroidism, it is most common preventable cause of intellectual disability. And it had an inverse relationship with age at treatment initiation and IQ present later in life. If longer the child goes untreated and undetected, the IQ will be delayed. Congenital hypothyroidism may be either permanent or transient. The thyroid dysgenesis, particularly ectopic thyroid gland, is the most leading cause of permanent hypothyroidism. I have stated few important causes of transient hypothyroidism. Most of the newborns were asymptomatic during the early infancy period since the thyroxine crosses the placenta. The signs and symptoms of hypothyroidism include lethargy, post-grade feeding problems, constipation, puffy faces. If it is associated with hypoglycemia, micropenis, undescended testis, we have to think in terms of central hypothyroidism. How to diagnose a case of congenital hypothyroidism? It starts with newborn screening. It is usually done after 72 hours of life and not later than 5 days. The sampling is done with cord sample or postnatal heel prick. We are going to interpret the thyroid screening, which is done at day 3 of life. If the TSH is more than 40, then we have to send confirmatory venous sample for both free T4 and TSH, and we have to start the treatment. If it is between 20 to 40, we have to repeat the sample after 7 to 10 days with both free T4 and TSH together. And if it is still more than 20, we have to start the treatment. If it is between 10 to 20, we have to repeat the sample after a week. Then persistence is there beyond 2 weeks of age, then we have to start treatment. If it is less than 20, no treatment is required. As free T4 less than 1.17, irrespective of TSH, is indication to start the therapy. Why the role of thyroid imaging, why it is mainly done to find out the etiology of congenital hypothyroidism, and it also helps us in counseling the parents. Can be visualized by ultrasound as well as scintigraphy. Ultrasound can be done anytime before or after treatment, but scintigraphy should be done before starting the treatment or within 7 days of starting the treatment. Here are few images regarding the nuclear scans. Now I would like to conclude my discussion with a take-home message. Every newborn must be screened for congenital hypothyroidism. Infants with screening TSH more than 20 of serum units or more than 34 if sample taken between 24 to 48 hours of life should be recalled for confirmatory sample. Both free T4 and TSH should be measured during recall. In suspected transient hypothyroidism, re-evaluation for permanency can be attempted at 3 years of age. Regular growth and development monitoring and hearing evaluation must be done. Scintigraphy especially required to rule out the ectopic thyroid gland. Screen for cardiac defects and hearing in case of congenital hypothyroidism. Now I would like to invite Dr. Ramya ma'am to speak a few words regarding nuclear scan.
Good afternoon, everyone. I am Dr. Ramya, Senior Resident from SRM Medical College. I would like to give a few importance about the role of thyroid imaging in the etiological diagnosis of congenital hypothyroidism. Basically, both USG thyroid and thyroid scintigraphy is essential and also both complement each other in the etiological diagnosis of congenital hypothyroidism. Ideally, thyroid scintigraphy should be done either before starting treatment or within 7 days of treatment initiation, whereas USG thyroid can be done anytime, any point of time, as already discussed. So here I would like to give instances where USG thyroid and thyroid scintigraphy will give us clue about the diagnosis. So the first instance is when the gland is absent in USG thyroid, there are two possibilities that we can get. In nuclear scan, if there is no uptake at all and there is no gland in USG, it is very clear that there is possibly thyroid agenesis. However, the essential point here to remember is that when the gland is not present in the thyroid bed, it is essential to look for the radioisotope uptake in elsewhere region, especially in the along the track where the thyroid gland develops. So the importance of nuclear scintigraphy is especially in ruling out ectopic gland. So this is the first incident. The second one is there could be a possibility of small gland in USG thyroid. And upon thyroid scintigraphy, we can have an either absent or a reduced uptake, which goes more in favor of thyroid hypoplasia. This is a case that we got up with the first case where one side of the lobe is hypoplastic and also reduced uptake. The third instance would be the enlarged gland, where sometimes newborn will be presented with a fetal goiter too. Instead, in such cases, if there is an increased uptake in thyroid scintigraphy, it goes more in favor of maternal iodine deficiency. Either normal or increased uptake will goes more in favor of dysharmonogenesis, which is a second most common cause of congenital hypothyroidism. If there is a confusion with dysharmonogenesis, we have to go ahead with perchlorate discharge test. This is basically to identify organification defect, if any, namely TPO deficiency. And the other instance where the gland is enlarged, but however there is no uptake at all, then the possibilities are there could be a maternal antithyroid drugs or a sodium iodide importer gene mutation. And the final instance could be the gland is normal in size and also at the thyroid bed. The possibilities here, there could be a normal uptake or an absent uptake. If there is an absent uptake, even with the gland normal in position, then these are the possibilities. And all these possibilities that is quoted here, that is TSH antibody or receptor defect, NAS gene mutation, iodine excess. Of this, TSH antibody and iodine excess are basically cause of transient hypothyroidism. The NAS gene mutation can present as transient or permanent too, with a mild or a moderate to severe hypothyroidism. So the main important thing is, if it is a sodium iodide imported defect, the uptake is not only absent in thyroid, the uptake is universally absent in all the iodide uptake areas like salivary and gastric mucosa. So this is the main importance of looking at both the USG and nuclear scintigraphy for the etiological diagnosis. So basically, if the child is not evaluated before starting treatment, if the child is not evaluated before starting treatment, then we ideally the child has to be evaluated after the age of 3 years to make sure that neurodevelopment is not compromised. So at age 3 years, the protocol is we have to stop thyroxine for a period of 4 weeks, and we have to followed by it the free T4 and TSH should be checked. As already mentioned, ideally TSH of more than 30 is necessary for subjecting the kid to scintigraphy. However, mild elevation can also be used if the suspicion of the dysormanogenesis is quite high likely. The other thing is if also the hypothyroidism is more of a transient. If the transient hypothyroidism is more suspected, then it's very important to recheck the permanence of CH at 3 years of age. So if the parents are not willing for scintigraphy because of the financial issues or whatever the reasons, the other measure that can be done to look at the permanency of CH is we can taper the dose of thyroxine to 1/3 and recheck the T4 and TSH at 2 to 3 weeks. If TSH is increasing beyond 10, this is also again an important measure of permanence of congenital hypothyroidism. So either we can stop the drug and go for a nuclear scintigraphy, or taper the drug to 1/3 and look for TSH for increase more than beyond 10. However, if the thyroid profile test at 4 weeks and subsequently if still normal even at subsequent weeks, it basically tells us that the hypothyroidism is more of a transient in nature. Now, with respect to the second case, the few points that I would like to add on is, as like in first case, newborn screening test was missed. So that tells us the importance of newborn screening in every kid that has to be done. Here the kid is picked up at 1 month of age with very high TSH. And again, free T4 and TSH should be done together to look at the severity of hypothyroidism and for the further follow-up also. And in this case, ideally, the very high TSH is more typical of thyroid agenesis. And basically, we should have stopped the thyroxine at 4 weeks. But in that case, considering the poor compliance and also very high TSH at every point in between time, we just took a 2 weeks period, where the 2 weeks post period only, the child had a very severe TSH elevation of more than 250, which by itself says it is a more of a thyroid agenesis. As the parents were willing, we went ahead with thyroid scintigraphy and gave them the counseling about the need for lifelong treatment. These are the take-home messages. I would like to ask Dr. Balaji sir to carry forward with nuclear imaging. Take over to you, sir.
Yeah, almost everything Dr. Ramya has covered. It's already late. So just one practical point I want to add is nuclear scan is important, but we cannot delay the treatment because of practical difficulties. It might not be available in our setup. We have to send it outside. But do not delay the treatment for the sake of nuclear scintigraphy. We still have window of 1 week after starting treatment. So start treatment. My advice is start the treatment. Within 1 week, try to get your nuclear scan. So that might be a better option rather than not starting treatment. Because within 2 weeks of diagnosing, within 2 weeks of life, we have to start treatment, or otherwise the IQ will start getting worsening. So that's the important take-home point for. So scan is important, but do not wait for starting treatment for the scan results. Thank you. Thank you.
So any queries? So if there are no queries, we will thank you, Dr. Vinoda, Dr. Ramya, and Dr. Gayatri and Balaji sir for the great insight on congenital hypothyroidism and this investigation. We will move on to the next presenter, Dr. Vijay from Melmarottur Medical College, hacked by Helminth. Over to you.
Good afternoon to all. On behalf of Department of Pediatrics, MAPIMS, we are going to discuss about a child who has been hacked by helmet. Here, a 4-year, 6-month-old male child brought with complaints of rolling of eyes, stiffening of limbs, which lasted for 5 minutes. And it has been resolved after an IM dose of midazolam. And further, the child also had complaints of 3 episodes of vomiting. And probing into history, there is no prior history of seizures, and there is no history of recent vaccination, and the child was developmentally normal, and the antenatal period was also uneventful. So here, the significant history is history of intake of undercooked pork, which is major significant history, and there is no history of animal bite, and also there is no history of previous hospitalization. And after initial stabilization, on examination, the child was alert, active, and affable. Hydration was fair, and vitals were stable, and anthropometry were within normal limits according to IAP chart. And systemic examination of the child was also normal. Investigations like complete blood count, renal function test, serum electrolytes were normal, and chest X-ray done also found to be normal. And Mantoux test in view of suspecting tuberculoma was also done, which was found to be normal. And since the child is having a focal seizure with also a significant history, the child was proceeded to a neuroimaging. And based on neuroimaging impression, the child was found to have an active neurocysticercosis in the colloidal vesicular stage in the right occipital lobe. So the neuroimaging is also followed by means of MR spectroscopy, which showed an amino acid peak, which mainly differentiates it from tuberculoma, which shows characteristic lipid peak. So these are the possible differential diagnosis. Here, the most likely diagnosis will be neurocysticercosis based on the history and based on the neuroimaging findings. Here, the chance of tuberculoma is less, and it is ruled out by means of chest X-ray, which was normal, and Mantoux test, which was negative, and MRI brain showed a characteristic amino acid peak and not a lipid peak. And there's no evidence of viral encephalitis. There's no prodrome phase of fever or an altered sensorium, and there's also no evidence of febrile seizure. And because there is no onset of fever, there is no fever at the onset of seizures. And MRI brain also rules out other structural abnormalities in the child. So before initiating the treatment, the ophthalmology clearance was obtained in order to rule out ocular cysticercosis, and then followed by pulmonary clearance in order to rule out tuberculoma. And before initiating anti-parasite therapy, the child was started on steroids to prevent the inflammatory response to the anti-parasitic action. So the medications first we started are seizure medications like levetiracetam at the dose of 20 mg per kg per day, which was started IV and then followed by oral medication, and then followed by prednisolone at the dose of 2 mg per kg per day for 5 days. And from initiation of steroid on day 3, the child was started on albendazole at the dose of 15 mg per kg per day at the twice daily for 14 days. So during the course of hospital stay, the child had no further seizure episodes, and he remained affable, and the appetite and activity improved. The child was discharged with advice of continuation of antiepileptics for 6 months, and then completion of course of albendazole and steroids, and with routine vaccination advice. Discussion in this neurocysticercosis in India is one of the endemic region for neurocysticercosis. The prevalence of neurocysticercosis causing epilepsy is 20 to 50% in some regions. Higher incidents are noted in rural areas when compared to urban areas due to poor sanitation and poor consumption. South India and North India contribute the major contributors when compared to other regions. So transmission, the infective form is Cysticercosis cerevisiae, which is a larval form of tinea. So the transmission can occur in both vegetarians and non-vegetarians. But the catch is in case of consuming eggs, the person consuming the contaminated eggs, here the oncosphere reaches the intestine, then it causes oncosphere hatches and it causes a penetration of intestine and reaches the circulation, and then it reaches the target organs like brain and muscles. But if the person consumes the pork, which contains a larval stage, it reaches the intestine and it develops into a larval adult worm, but it cannot penetrate the intestine and it cannot reach the blood circulation and the other target organs. but the worm remains in the intestine and it continuously sheds the proglottids and other eggs. If the same person get contaminated with the poor sanitation facilities or consumption of eggs, he can get neurocystic sarcosis. So this is the life cycle of neurocystic sarcosis. Here, the accidental ingestion of egg causes the oncospheres to reaches the intestine, which causes the penetration of intestinal wall and reaches this systemic circulation, and then it reaches this and reaches the brain, and which where it develops into a worm, producing a characteristic ring-enhancing lesion with protocolex. So the most common presentation of neurocystic sarcosis includes seizures, and other manifestations may also include headache, nausea, vomiting if the involvement is at the level of CSF, and sometimes there may be cognitive impairment or psychiatric symptoms. So the characteristic features will be there will be focal neurological deficits based on the site of lesions. So there can be features based on the location of lesion. If the lesion is at the level of parenchyma, the most common features include seizures, and the seizures will be most commonly focal when compared to generalized, and there will be single episodes of seizure when compared to recurrent, and the neurological deficits will be minimal. So the intraventricular neurocystic sarcosis contribute about 20% of overall lesions. It will present with features of obstructive hydrocephalus, signs of raised ICP. But another one is subarachnoid neurocystic sarcosis, which causes the inflammation of arachnoid villi and also produces the signs of meningeal irritation. Spinal neurocystic sarcosis causes the features of transverse myelitis and radiculitis. Ocular neurocystic sarcosis is one of the dangerous condition. The target areas are vitreous and the retina, which causes the iridocyclitis and retinal detachment. So if the child presenting with the focal seizures and there was a history of significant pork intake, and then they can be proceeded with neuroimaging. Here, MRI is preferred over CT scan because the initial few stages like vesicular, colloidal vesicular, and granular nodular stages can be easily picked up by means of MRI when compared to CT. But the later stages like calcified stages can be easily picked up by means of CT. So if the presence of protocolex in the ring-enhancing lesion is a characteristic feature which differentiates from its differential diagnosis, and if there is a ring-enhancing lesion with a central scolex, and it can also be proceed with MR spectroscopy, which normal, and in case of neurocystic sarcosis there will be an amino acid peak, but in case of tuberculoma there will be a lipid peak. So these are the differentiating features between tuberculoma and neurocystic sarcosis. In case of tuberculoma, there will be a second features like fever and lymphadenopathy will be present, and which is not present in neurocystic sarcosis. And there will be meningitis in case of tuberculoma, and it will be absent in neurocystic sarcosis. And tuberculoma, which initially starts as a single lesion, and then the gradually increase in size, and they fuse together to form conglomeration, so which causes the midline shift. But in case of neurocystic sarcosis, they will not cause midline shift, and the size remains less than 2 cm. Location of tuberculoma is most commonly in posterior fossa, whereas neurocystic sarcosis is at the level of gray-white matter junction. So they can be easy. Both will resemble as a ring-enhancing lesion, but tuberculoma will show a central necrosis, which will not be differentiated. But the neurocystic sarcosis characteristically shows the ring-enhancing protocolex in the center, and MR spectroscopy shows amino acid peak, whereas tuberculoma shows a lipid peak. So the neurocystic sarcosis initial 3 stages shows ring-enhancing lesion with the central scolex with surrounding pericystic edema, whereas in case of tuberculoma there will be a fusion of lesions which is called as conglomeration, and there will be a midline shift. So management of neurocystic sarcosis includes 3 main stages. First, initially anti-seizure medication. If the child is presenting with active seizure, he should be stabilized according to protocol with standard seizure medications. Initially IV medications and followed by oral medications, and the anti-seizure medication should be continued for at least 6 months. And after 6 months, the neuroimaging should be repeated. If the lesion is resolving after assisted therapy, then the dose can be tapered and stopped. If the lesion is not resolving, then or the lesion is calcified, then the anti-seizure medication should be continued for a period of 2 years. Then it's followed by anti-inflammatory therapy. The anti-inflammatory therapy include And before initiating anti-inflammatory therapy, chest X-ray and Montauk test should be done to rule out TB. So the anti-inflammatory therapy includes dexamethasone at the dose of 0.15 milligram per kg per dose 4 times a day, or prednisolone at 2 milligram per kg per day for 5 days. After initiating the anti-inflammatory therapy, after 3 days, the antiparasitic therapy can be initiated. Before initiating antiparasitic therapy, ocular cysticercosis should be ruled out by means of ultrasonography B scan, because if it is not identified, then it will cause a rupture of the cyst, which will cause inflammatory reaction. And after initiate, in case of calcified lesions, the antiparasitic therapy is not required. The initial 3 stages like vesicular, colloidal, granular, nodular stages required active treatment. The drug of choice will be albendazole at the dose of 50 milligram per kg per day at the 2 divided dose, starting from third day of initiation of anti-inflammatory therapy. It should be continued for 7 to 14 days. If the lesion is multiple or 2 to 5 lesions, the albendazole should be combined with the praziquantel at the dose of 50 to 100 milligram per kg per day for about 28 days, and it should be the anti-seizure medication should be continued for 2 years. So conclusion is the neurocysticercosis is one of the major cause of epilepsy in endemic regions, and the diagnosis based on MRI and serology. Most commonly, serology will be negative, and the diagnosis will be mostly based on neuroimaging and clinical criteria and with history. The treatment remains as albendazole, steroid, and antiepileptics. And the major role of prevention is through sanitation, hygiene, and education. Thank you.
So regarding this case, we presented for the to give insight into the space occupying lesion to differentiate between neurocysticercosis and tuberculoma. For serology, there is no need to do serology in this case because as it is a cost involved, only MRI is enough, or CT. So if any queries?
It was a good presentation, Doctor.
Thank you, sir.
And how about any clinical way of thinking that it is NCC? Clinically, you got any information? No. Imaging only.
So the child has focal seizure.
It was focal seizure.
And it's the first episode, sir.
So it was focal seizure. Then drug of choice for focal seizure, like you give levetiracetam, right?
Yes, sir.
It's okay, or you want to go for carbamazepine type of drugs?
So initially we started with levetiracetam, sir. The child responded, so we didn't change it. So we continued.
And edema was not that much, right? For
Yes, sir. Yes.
And calcification, like it was active, or you feel it's
Active with Scolex, sir.
Sir, it is active lesion. There's a presence of central Scolex in the lesion.
Okay, doctor. Okay.
Thank you.
Now I call upon Dr. Syed from Satya Sai Medical College to present his case.
Welcome, Mr. Madam. Can you hear me? Madam, can you hear me?
Yes, sir.
Madam, one small question.
Yes.
Whether spinal screening has been done for this child? MRI spinal screening.
Yes, sir.
Okay. So was there anything specific in MRI spinal screening?
No, sir. It was normal, sir.
Okay. Okay. So basically, for all children, we have to do a MRI spinal screening apart from the ocular screening, ophthalmic
sir.
screening.
Okay, sir.
And one more thing is, was the parents screened, or was the contacts screened and treated?
No, sir.
I think one should treat the siblings and contacts so that they won't have such episodes. All the
Okay, sir.
parents and siblings. Good
Okay, sir.
presentation. Overall, a good presentation. Thank you.
Thank you, sir.
Dr. Syed, please start your presentation.
Sir, Dr. Syed, your mic is not on. Yeah, it's not audible for us.
Dr. Syed, please start your presentation.
Good afternoon, ma'am. Are you able to hear me?
Yes, sir. Please continue.
Good afternoon, everyone. My name is Dr. Syed Wakhas Ahmed, GR2 from the Department of Pediatrics, Sri Sathya Sai Medical College. Today, I am going to present a case of CDH who got admitted in Sri Sathya Sai Hospital. We got a call from the OBG department regarding the delivery with mother named Anita, G4P2L2A1. is late preterm, 36 weeks plus 5 days. Mother is a known case of PIH taken for emergency LSCS. We prepared for the newborn resuscitation with following mother's detail: 27 years old, gestational age 36 plus 5 days. In first trimester, which is regarding first trimester, which is uneventful, but except incidental findings of umbilical hernia was made in USG for mother. Regarding second trimester, anomaly scan was done and found to have fetal dextrocardia. Regarding third trimester, mother diagnosed with PIH at 34 weeks and was started on tablet labetalol 100 mg BD. USG, which is growth scan done at 35 weeks plus 1 day, shows the fetal heart is located in the right hemithorax and closely seen abutting the right lateral chest wall with the cardiac apex in normal position, suggestive of dextrocardia. Right lung could not be delineated, suggestive of hypoplastic lung. Coming to the past obstetric history, in pregnancy 1, spontaneous miscarriage was noted at 3 months, whereas second and third pregnancy was normal with no complications noted. Coming to the baby detail after birth, baby delivered after 36 plus 5 weeks, which is late preterm, on 22 January 25. Birth weight was 3865 grams. The baby was male child. Apgar score at 1 minute is 7 by 10, 5 minutes 8 by 10, and 10 minutes 9 by 10. Baby cried immediately after birth. Vitals after birth were heart rate 146 per minute, saturation 87% at room air, respiratory rate 66 per minute, and temperature 36.5 degrees Celsius. Baby shifted to NICU, kept under the warmer, started on oxygen 6 liters O2 via oxygen hood, IV line secured, and started on IV fluids 10% dextrose. OG tube inserted and the cap kept open for the decompression. Repeat examination done in NICU. The vitals checked in NICU were heart rate 138, respiratory rate 64 per minute, SpO2 96% at 6 liters O2, in which pre-ductal saturation 97% and post-ductal 95%. In abdomen, shape was scaphoid. Coming to systemic examination, in case of respiratory system, reduced air entry was there, right, more towards right than left. Grunting was present, nasal flaring was present, intercostal retractions, tachypnea, increased work of breathing was there. Downey score coming in 4. Per abdomen examination shows scaphoid in shape. Course in NICU, we kept the baby on O2, 6 liters per minute via hood. Baby was kept under warmer, placed OG tube and cap was kept open. We kept baby on NPO and started on IV of 10% dextrose at 9.5 ml per hour. Some investigation done shows blood investigation we have done as CBC, which shows normal. Blood gas VBG showing hypocapnia and hypoxia. Chest X-ray taken on the same day of delivery, which shows loss of lung volume noted right side. Dextro position of cardia noted with the loss of normal cardiac silhouette at right side. So calibration of the chest X-ray is dextro position of cardia with loss of right lung volume. 2D echo shows dextrocardia with small ASD and large PDA with left to right shunt. Dilated right atrium and right ventricle with moderate tricuspid regurgitation with moderate PAH. Child referred to the higher center, that is ICH, at 7 hours of life in ambulance on oxygen accompanied by pediatric PGs. Indication for referral for definitive surgical corrections. As child admitted in ICH in NICU, on the same day X-ray was done, shows mediastinal shift to right, soft tissue density to left thoracic cavity with radiolucency over inferolateral aspect of chest. Blood culture CBCs USG cranium and abdomen, in which USG abdomen shows abdomen axis obscured. On day 1 of life, echo was done, shows patent foramen ovale, PDA, which is left to right shunt. On day 3 of life, CT chest was done, of aventration with severely thin out left hemidiaphragm, suggestive of left hemidiaphragm hernia. On day after the baby got stabilized, on day traumatic hernia repair with mesh under GA. In intra-op findings, they proceed through transabdominal approach. Defect of size 8 cm into 5 cm along the posterior lateral aspect of left hemidiaphragm. Left lobe was the only content in this child. Now coming to the post-op course, baby was kept on NPO for day 1. NG started from post-operative day 2. Baby was kept on NIV, in which FiO2 was 40%, PEEP 7, weaned off from NIV on post-operative day 5. On post-operative day 8, X-ray was taken, which shows mediastinal shift to right, lung field expansion was present, and normal gas was there in the abdomen. Suture removed on post-operative day, discharge on post-operative day 12. This is the discharge summary of a child from ICH hospital. Now coming to the discussion part, congenital diaphragmatic hernia. It is a connection between abdominal and thoracic cavity with a diaphragmatic defect. Diaphragm is formed by the fusion of septum transversum and pleuroparietal membrane. If there is defect in the fusion of septum transversum and pleuroparietal membrane, there will be a herniation of content from abdomen into the thorax. Incidence and types. Incidence is 2,000 to 5,000 live birth. There are 3 types of CDH, which is Bogdalak hernia, which is posterior lateral, Morgagni, which is usually present in anterior, and central. The content which is present in Bogdalak hernia most common is stomach, intestine, liver, or spleen, and here the child will be symptomatic. Coming to Morgagni, the content present here is liver or small bowel loops. Here the child will be mostly asymptomatic. Coming to the pathophysiology, congenital diaphragmatic hernia is associated with the lung hypoplasia, pulmonary arterial hypertension, and ventricular dysfunction, in which there will be right ventricular hypertrophy and right ventricular failure. It is also associated with left hypoplasia due to pulmonary venous hypertension. Presentation of a child at birth with severe respiratory distress, barrel-shaped chest, scaphoid abdomen, reduced breath sounds on the affected side. It is also associated with anomalies. The most common anomalies usually associated with the CDH is cardiac anomalies, which is 36%, followed by genitourinary and CNS defect, which is 15%. It also associated with the It's also associated with trisomy 18, 13, and 21. Coming to the prenatal diagnosis, the most common diagnostic method we used prenatally is USG, in which more than 50% of CDH cases detectable at a mean gestational age of 24 weeks. The fetal MRI is used for prognostic factor. It measures total volume plus quantification of liver mass herniated. The prognostic parameters is lung to head ratio. If the lung to head ratio is less than 0.6, it is associated with no survival. If lung to head ratio is more than 1.35, it is associated with 100% survival. Poor prognosis also involve intrathoracic liver herniation, side of herniation, right side worse than the left, isolated or syndromic disease or associated anomalies, as discussed before. Right-sided CDH. Right side CDH is more severe than left side CDH. It has lower survival rate, in which a greater proportion of ECMO is required, and it's with high morbidity. Now coming to the management, antenatal aspect, a role of antenatal fetoscopic tracheal occlusion procedure, in which increased survival among patients with severe CDH, however, associated with higher rate of pre-rupture of membrane and premature labor. Delivery timing is preferred at 39 weeks. Institutional delivery is required, no preferred mode of delivery. Now, after birth in delivery room, intubate if any distress is present. Bag and mask and CPAP is contraindicated in CDH. Pre-ductal saturation target is 80 to 95%. NG tube has to be placed with cap should be open. Coming to the treatment of pulmonary hypertension. Hypertension developed due to hypoplasia of lung, where abdominal in the CDH, abdominal content herniate into thorax, which give less space to lungs, which cause hypoplasia and uh, and cause pulmonary hypertension. So consider anti-PPHN measures such as sedation or sildenafil. Indication for nitric oxide, pre or post saturation difference more than 10% or oxygen index more than 20. Suprasystemic pH with right to left shunting through the foramen ovale considered prostaglandin E1. If oxygen index is more than 40, then considered ECMO. After the child gets stabilized, the surgical timing, the required mean arterial pressure, mean airway pressure normal for gestational age, preductal SpO2 level of 85 to 95% on FiO2 less than 50%, lactate below 3 millimole per liter, urine output more than 2 ml per kg per hour. The complication which include in case of CDH, in case of short-term shock, pulmonary hypertension, right heart failure, abdominal compartment syndrome, patch abscess, GERD, etc. Whereas long-term complications include recurrent respiratory tract infection, recurrent hernia, GERD, failure to thrive, hearing loss in 30 to 50%. During follow-up, anti-GER measure should be done, growth monitoring has to be done, respiratory issues and any has to be noted, and echo has to be repeated, and hearing test has to be done. Thank you.
Any queries?
Doctor, nice presentation. Was it eventration? There was a doubt, right? Eventration or hernia. So it was finally, what was it actually? CT suggested.
Sorry, sir, I can't hear you.
Able to hear, doctor? Able to hear, doctor?
Yes, sir. Yes.
Yeah. So the CT suggested eventration query hernia, right? So finally, what was the diagnosis? Okay, I think internet issues are there. You can continue, doctor.
Yes.
Okay. Now I call upon Dr. Aravind from Chettinad Hospital and Research Institute to present his case. Sir, Aravind sir, are you there?
Just a minute, madam. Few technical issues in our side.
Okay.
A very good afternoon, everyone. Am I audible?
Yes, doctor.
Okay. Myself,
Sir.
Dr. Aravind, second year postgraduate from the Department of Pediatrics, CHRI. I'm going to present the case, is it TB, Diagnostic Dilemmas. My moderator for this topic is Dr. Rajkumar, sir. We'll move on to the case report. A 16-year-old female child brought to OPD with chief complaints of fever for 4 days, abdominal pain for 3 days, and nausea for 3 days. Issue on admission, the child was apparently normal 4 days back after she developed a high-grade fever, which was maximum recovered temperature of 104 degree Fahrenheit, relieved with the paracetamol. No history of evening rise of temperature. And history of abdominal pain for 3 days, which was diffuse in nature, no aggravating and relieving factor. And history of nausea for 3 days, with one episode of vomiting containing food particles, not blood and bile stain. No history of loose stools, constipation, abdominal distension, no history of boning maturation, no history of ear pain and ear discharge, no history of weight loss, no history of TB contact. The past history, child is being taken care at orphanage home for 2 years, and history of anemia, treated with the oral iron supplement in the OPD basis, no history of previous surgery and hospitalization. Her antenatal history, birth history, and postnatal history was uneventful. She is immunized till 5 years of age according to national immunization schedule, and developmentally normal child. Her menstrual history, she attained menarche at 14 years of age with a regular cycle, and family history, her mother died 4 years back, cause not known. Her father is an alcoholic. Child was transferred to orphanage home by the father with his consent. Her antemental status, she comes under severe thinness. At the time of admission, child was conscious oriented. And lymph node examination, bilateral inguinal lymph nodes were palpable, largest measuring 3 cross 2 centimeter, firm, non-tender, and mated. No pallor, no cyanosis, icterus, and edema. Vitals were stable at the time of admission. The head to examination, everything was normal. BCG score present, no other peripheral markers of TB. Systemic examination wise, per abdomen, soft tenderness noted in the right hypochondrial region, iliac fossa, and lumbar region. And liver palpable 2 centimeter below right costal margin, with liver span of 11.5 centimeter, no splenomegaly. Other system examination was normal. So at the time of diagnosis, at the time of admission, uh, at the time of admission, we have two differential diagnoses. One is a tropical fever, because child had acute febrile illness of 5 days with a tender hepatomegaly. Another differential diagnosis is acute abdomen, because acute onset of abdominal pain with diffuse tenderness noted in the noted with a short fever history. So we investigated the child. CBC was normal, CRP was reactive, and LFT or FT serum electrolytes were normal. Used abdomen was normal. In view of high-grade fever spikes with raised CRP, we started empirical antibiotics IV ceftriaxone after sending blood culture. When pancreatitis workup was done, serum amylase and lipase was sent, was normal. And in view of persistent abdominal pain and fever spikes, we planned the CT abdomen with the contrast studies. In that CT abdomen, it showed multiple hypoechoic lesion. Can you able to see my slides?
Yeah, doctor, but not the CT.
There's some delay, sir. Sorry. Okay. CT abdomen showed a hepatomegaly with a multiple hypoechoic lesion, and in kidney it showed some focal enhancing lesion in the right kidney. So So the point on day 3 of admission, we have 3 differential diagnoses. One is tuberculosis and pyogenic liver abscess and fungal liver abscess. For tuberculosis, hello.
You are audible, doctor.
Just a moment. There is a technical issue in our side.
Okay. Second பண்றாருங்க. Okay. Now the slides are visible.
Yes, sir. Visible, sir. Please proceed.
Okay. On day 3 of hospitalization, we have 3 differential diagnoses. One is tuberculosis and pyogenic liver abscess and fungal liver abscess. For tuberculosis, the favorable point for tuberculosis, child is small-aged children with significant native lymph node, and liver imaging showed suggestive of possibility of granuloma, and the chest X-ray showed a few mediastinal lymph node were present, and CRP was positive. This is the X-ray of the child. The against feature for tuberculosis, MAN2 was negative, IGRA was negative, and CBNAT was negative. For pyogenic liver abscess, the favorable point for pyogenic liver abscess, child had persistent high-grade fever with a tender hepatomegaly, and CCT showed a hypoechoic liver lesion. It's probably due to granuloma or abscess. And against the feature for pyogenic liver abscess, child had normal total count, and she's not response to broad-spectrum antibiotics and anaerobic coverage. The third differential diagnosis, fungal liver abscess. The possibilities of fungal liver abscess, child from orphanage home with no reliable past history, and liver CCT showed suggestive of possibility of fungal abscess. The unfavorable point for fungal liver abscess is serology is negative and no other features of immunosuppression clinically present. So we repeated the blood culture and for 3 days and fungal culture, but that was sterile. Then considering the above differential and persistent fever spikes in spite of broad spectrum antibiotics, we started meropenem, vancomycin, and metronidazole were started. Echo done for infective endocarditis workup that was found to be negative. In spite of above measure, child continued to have persistent fever spikes in the second week of hospitalization. So we repeated the USG abdomen to look for possible changes in the morphology of liver lesion. In that USG, it's more favor of granulomatous lesion. So there is some lag in.
Yes, sir.
Sorry. Sir. Okay. We repeated the blood culture for consecutive 3 days and fungal culture that was sterile. Considering the above differentials and persistent fever spikes, in spite of starting broad spectrum antibiotics, child had persistent fever spikes. So we started meropenem, vancomycin, and metronidazole. Echo was done. Echo showed the echo was done for infective endocarditis that was found to be negative. In spite of above measure, child continued to have persistent fever spikes in the second week of hospitalization. So we repeated the ultrasound abdomen to look for possible changes in the morphology of liver lesion. In that, it's more favor of granulomatous lesion and neoplasia rather than the abscess as per radiologist's opinion. So in view of suspicious of underlying infection and malignancy like lymphomas, liver angiosarcoma, and metastasis, so we planned for PET scan. So PET scan showed metabolically active multiple innumerable discrete with the coalescing enzyme with the coalescing hypodense lesion in the both lobe of the liver with the SU max of 16.6. SU max is more than 2.5. It's a possibility of malignancy. And in kidney, it showed few hypodense lesion in both kidney with the SU max of 12.4. And metabolically active lymph nodes present in the abdominopelvic, bilateral inguinal, and few subcutaneous deposit in the lateral wall of thorax and abdomen with the SU max of 15.5, with the few subcentimeter mediastinal and bilateral axillary lymph node with the SU max of 3.5. So at the point we have two differential diagnoses. One is lymphoma and another one is tuberculosis. Child had a pyrexia of unknown origin because child had continuous fever spike for 3 weeks and significant inguinal lymph nodes clinically present, and X-ray showed mediastinal lymph node was there, and PET scan showed multiple lymph node involvement with significant SU max. The against feature for lymphoma, in spite of lymph node and liver involvement, but spleen was completely spared in this case. For tuberculosis, child had pyrexia of unknown origin with a multiple significant lymph node with the liver involvement can be a extrapulmonary tuberculosis. Multiple time repeated CBC was normal. The against feature for tuberculosis we already saw MAN2, EGRA, and CBNAT was negative. So in view of above clinical pictures, we planned for inguinal lymph node biopsy under general anesthesia. Then we sent the sample to histopathology. It showed multiple caseating necrotizing granuloma, but AFB and CBNAT of lymph node was done twice. That was negative. So this is the picture of the histopathology. And in view of which AFB done on histopathology sample itself was positive for AFB. This is a acid smear showing one acid phos bacilli, and immunohistochemistry marker also done to rule out Hodgkin's lymphoma that was negative. So considering the clinical history, examination finding, and histopathological evidence, a provisional diagnosis of disseminated extrapulmonary tuberculosis was made. Pulmonologist's opinion was sought, and ATT was started on 27/11/2024. Then child was registered in Nikshay and was started on high protein diet. Sibling also screened for TB that was found to be negative. Then child became afebrile after starting ATT, after 7 days of starting ATT. Then child is hemodynamically stable and hence being discharged. So on follow-up, after 1 week of discharge, that means 2 weeks of ATT, child appetite was improved and liver span is decreased. Now currently, child is doing well and she's afebrile for almost 7 weeks since starting ATT with a good weight gain. So coming to the discussion, tuberculosis can be extrapulmonary TB and pulmonary TB. Here I'm focusing the extrapulmonary TB. These are the types of extrapulmonary TB. Here I'm focusing the tuberculous lymphadenitis and abdominal tuberculosis. Tuberculous lymphadenitis is the most common presentation of extrapulmonary tuberculosis. Clinical manifestation depends on the site of lymphadenopathy and the immune status of the patient. The most common affected lymph node is cervical lymph nodes, followed by inguinal, axillary, mesenteric, and mediastinal involvement. Classical classification of peripheral tuberculous lymph nodes. Stage 1 is reactive lymphadenitis. Stage 2 is periadenitis. Stage 3 is cold abscess. Stage 4 cholestatic abscess formation. Stage 5 sinus tract formation. So approach to tuberculous lymphadenitis. If the lymph node is more than 2 centimeter in one or more site, if it is mated lymph node with cold abscess with or without sinus, if it is no, we can try with antibiotics for 7 days course and review after 2 weeks. If it is not response to that, we'll move on to the FNAC and if a needle aspirate from the lymph node. We'll send for CBNAT and AFB smear and MGIT. If it is positive for that, we'll consider as a TB and treat like a TB. If it is negative, we'll move on to excision biopsy and histopathology as treat per as per diagnosis. So classification of abdominal TB, intestinal TB, peritoneal TB, lymph node TB, hepatobiliary, and pancreatic TB. The presumptive TB workup for abdominal TB, if ascites is present, we'll go for paracentesis. If SAG ratio is more than 1.1, it considers cirrhosis and portal hypertension. If less than 1.1, we'll go for ascitic fluid protein. If it is more than 2.5 gram per deciliter, we'll go for ADA and other microbiological tests like AFB, gene expert, and TB culture. If it is positive for that, I will start ADT. If ascites is absent, ascitic fluid protein is normal, we'll move on to the algorithm 2 and algorithm 3. In algorithm 2, all patient will go for ultrasound abdomen plus CECT abdomen. If it is conclusive to TB, we'll start ATT. If it is not conclusive, we'll go for USG gated FNAC or core needle biopsy. If it is positive, if it is conclusive to TB, we'll start ATT. If it is inconclusive to TB, we'll start therapeutic trial of ATT. If ascites is absent, we'll go for ultrasound abdomen without CECT abdomen. If it's conclusive, we'll start ATT. If it's inconclusive, to start therapeutic trial of ATT. If not suggestive of abdominal TB, we'll consider alternate diagnosis like peritoneal carcinomatosis. So this is the rifampicin sensitive treatment for in case of RS rifampicin sensitive pulmonary TB or extrapulmonary TB. The regimen is 2 HREZD plus 4 HRE. In case of neuro and spinal TB, the continuation phase extend to 10 months. The drug dose, these are the drug dosages for rifampicin 10 to 20 mg per kg per day. For isoniazid 7 to 15, pyrazinamide 30 to 40, ethambutol 15 to 25, streptomycin 15 to 20. So these are the drug regimen for drug resistant TB. Thank you.
Oh, thank you, doctor. It's a nice presentation and insight to the disseminated tuberculosis. So any queries regarding this case?
Actually, very extensively evaluated case in
Yes, sir.
nicely evaluated for a pyrexia of unknown origin. That's good. But I somehow missed how we made the diagnosis of TB. Anything
They
you
have
got?
taken the
Sir,
lymph node biopsy.
actually, we taken the lymph node biopsy, sir. In that lymph node biopsy, we sent the sample to histopathology. It showed multiple necrotizing caseating granuloma, sir.
The inguinal.
Yes, sir.
Yes, sir.
Inguinal lymph nodes.
And how come the IGRA is negative? How to explain that? Like IGRA is an objective test, right? Mantle can come negative. IGRA should have come positive, right? IGRA suggested that high sensitization to TB protein is there.
So that was the confusing thing from beginning, sir. Other than the histopathology, everything else was actually not much suggestive of TB. That's why we'll have to go for this extensive workup. Probably one reason why this they are saying for extrapulmonary TB, the sensitivity of IGRA is little less compared to the pulmonary TB. So that could be one possibility, sir. They say that it is little variable compared to the pulmonary TB. So in few cases, they said sensitivity is even more than 80 to 90%, but in few extrapulmonary presentations, they are a little lower. And possibility of malnutrition could be another factor. Maybe that could be a reason why we didn't had any manto or IGRA positivity. So even the cases, necrosis, everything in the histopathology was very much suggestive of TB, but we couldn't get an microbiological confirmation in the form of CVNAT from the sample. So that is why we went ahead with AFB staining on the histopathology slide that showed the typical caseating granuloma, and that actually showed an AFP positivity, based on which we devised the further plan, sir. So that was a little atypical.
Yeah, but well managed.
Sir, one query whether this CBNAT was done on this specimen, sir?
Yes, ma'am. CBNAT we did twice on this specimen. Actually, we even repeated once again. In spite of that, actually it was negative.
Okay.
That is why we went ahead with the AFP of the formalin stained, preserved histopathology sample. Usually the yield is very low in the histopathology sample, but since we had no other option, then we went ahead with that, and luckily we got positive in that, and so based on that we started on treatment, and child is also now clinically responding.
Thank you, sir.
Thank you, ma'am.
So we are coming to the end of the 22nd edition of Chengai Pediatric Meet. For that, I would like to thank Dr. Subhash sir, President IAP, Chengalpattu, Dr. Arivoli sir, Dr. Saujan sir, Secretary, and Dr. Suresh Kumar for providing us the opportunity to host this meet. And Dr. Balaji sir, Academic Coordinator, and Dr. Harshavardhani, Academic Convener.
Thank you, ma'am. Thank you, ma'am.
I also extend my gratitude to all the presenters, all the HODs and faculties and PGs from various colleges like Arpaha Vinaha Medical College, SRM Medical College, Chettinad Medical College, Satya Sai Medical College, Kamakshi Memorial Hospital, Balaji Medical College, Chengalpet Medical College. Okay. So let us carry forward the knowledge we've gained today as we continue to strive for excellence in pediatric care. Thank you all.
Thank you.
Thank you.
Thank you.